Good evening, everybody, and welcome to another session of Intellectus Campus. Tonight's subject is viral hemorrhagic fever. We're having some connection problems. Dr. Carvalho is currently in Spain, and he's having some difficulty connecting. But I have listened to his presentation before, and I know the slides. So I'll start presenting, and hopefully he will be able to come on shortly. On the SADC group, we have introduced him. I'm going to go back to his introduction. He is a well-accomplished physician with expertise in endocrinology, and he's certified by the College of Physicians of Buenos Aires. His extensive experience in medical practice includes roles at the head of the hospital at the Hospital Anesia, and he's an associate physician at Zonal Hospital, the Mother Teresa of Calcutta. He has numerous things in his bio that's all in the chat. He has demonstrated his commitment in teaching globally, and we'll be very honored to have him speaking at the Victoria Falls conference and be one of the panelists. So the reason we wanted to deal with viral hemorrhagic fever is with the pandemic preparedness that is being spoken of. There is a great fear of Marburg and Ebola. We know that when there's an Ebola outbreak in Uganda, all our tourism in the region stops. So part of this presentation is to demonstrate what viral hemorrhagic fever is and what it is not, and that it's actually not all that scary. The main stuff that Dr. Carvalho deals with is dengue in Argentina. That would be his bread and butter. And what works for dengue also works for other viral hemorrhagic fevers, and it would also work for us here in Africa. So, sorry. If we look at what hemorrhagic fever is, hemorrhagic fever viruses are highly infectious RNA viruses. Now, if we've learned anything in the last 4 years, it is that RNA viruses are actually manageable by boosting the immune system and by using zinc ionophores. So these RNA viruses can lead to viral hemorrhagic fever in humans. And viral hemorrhagic fevers are mostly characterized by mild acute febrile syndromes, and they have coagulation abnormalities, which in the last 4 years is nothing new. But in the case of viral hemorrhagic fever, it progresses to generalized hemorrhage that can lead to multi-organ failure and to death. So if we look at the number of hemorrhagic fever viruses there are a huge number. But the ones that we would probably recognize in Africa fall under the filoviridae, which is Ebola and Marburg viruses. There are 6 kinds of Ebola virus, 1 kind of Marburg virus, and then the other ones that we would usually recognize are yellow fever and dengue. Also under the amyloviruses is West Nile virus, which is the hemorrhagic fever virus that we are most likely to see in our region. And you can see it's in exactly the same category as yellow fever. It's in the same category as dengue, and we should be able to manage it in our areas if we see it. I'm going to skip over this slide because it talks about the vectors. As we know from previous talks, when we're talking about infection control, we must look at the vectors. And rather than focus on the South American strain, I'm going to look at the global pattern of viral hemorrhagic fever. So if we look at Argentina, their main problem, as we've said, is dengue virus. Whereas if we switch to the African context, we've got dengue is pretty much not in sub-Saharan Africa, but West Nile virus is. So looking at it in a bit more detail, yellow fever we're seeing mainly up in West Africa. And that's why you have to have vaccinations to go to these places. Dengue is again north of us, but the one that is going to affect Zimbabwe is West Nile virus. And we need to know a little bit more about it and how it fits in with the treatment of hemorrhagic fever in other areas of the world. Certainly, we know that Japanese encephalitis is being managed in a similar way in places like Malaysia, and evolving treatments are showing to be effective. So West Nile virus, again, it's also present in Australia and in parts of Asia as well, but Africa seems to be the area predominantly affected. One of the slides that I have not incorporated in here, in the interests of time, is the picture of the evolving pattern of West Nile virus in the United States. And it's becoming increasingly prevalent in the USA, particularly over the last 2 decades, and it's blamed on travel from Africa and Asia. But some of it may also be compromisation of the immune system in the developed world. So West Nile virus before 1996 was first discovered in 1937 in the West Nile district of Uganda. It caused a mild feverish illness, and really it would cause severe illness like meningitis and encephalitis. And the message really for those on the call in the SADC region is when you see a patient with meningitis or encephalitis, just look into whether West Nile virus could be part of the differential diagnosis, because it's probably hugely underdiagnosed, because the testing that needs to be done on CSF. And we're probably missing a lot of these cases and simply calling them viral encephalitis or viral meningitis. Having said that, treatment isn't really that different. So you probably don't need to be too concerned, especially if you're in a rural area where you don't have access to lumbar punctures in a lab. It's again a case of exclude the dangerous stuff like malaria and treat what you see. Make sure the patient doesn't have meningococcal meningitis if you're dealing with a meningitis or an encephalitis. So what else is important about West Nile virus? And like malaria, it is transmitted by mosquitoes. So if you are in an area with a lot of mosquitoes and you're seeing an encephalitic or a meningitis type picture, and the patient also has hemorrhagic fever and is bleeding, certainly consider this as part of the diagnosis. So when we look at the transmission cycle, interestingly, the mosquito doesn't actually go through a cycle with humans, horses, or dogs, because dogs are another incidental infection. The actual cycle is between mosquitoes and birds. And so the mosquito bird cycle is the main cycle, but incidentally, if the mosquito bites a human, a horse, or a dog, then the virus may be transmitted. Now, the West Nile virus looks like many other RNA viruses. It has an RNA viral genome in the center that is surrounded by a nucleocapsid, which is made of protein. Outside that, there is a viral tegument and a lipid bilayer, which is also known as the viral envelope, which is the same as many other RNA viruses that we've seen. And then there is an envelope protein on the outside. And that envelope protein is what causes, and I'll deal with this in a later slide, the virus to attach to the human cell and insert the genetic material into the cell. The transmission cycle, as we've said, the reservoir is birds. The bird is bitten by a mosquito, and the mosquito transmits the virus back to birds. And the accidental hosts are people and animals. And interesting, dogs are also involved in this cycle. And some of the vets do recognize that West Nile virus can affect dogs as well. So if you're not bitten by mosquitoes, if you're in an area with a lot of mosquitoes, you need to be aware of this. And then again, not similar to malaria and to various other viral infections like hepatitis B, hepatitis C, HIV, transmission may also be by blood transfusion. So if a patient's had a recent blood transfusion and they present with a febrile illness, with hemorrhage, with a rash, and with encephalitis, you might want to consider this. Organ transplantation is less common in Africa. It does cross the placenta. It can happen if you are like Ebola, if you are nursing somebody who has a hemorrhagic fever and you're exposed to their blood or their secretions, and this includes in an occupational context. So if you are nursing somebody who has a hemorrhagic fever, you need to be very, very careful to not be subjected to their secretions. And it is probably also able to be transmitted to the infant in breast milk. So somebody who has got this condition should not be breastfeeding. So before 1996, what was noticed was that, particularly in Uganda, was this was a mild illness. It involved patients who had a fever. It involved young adults in Africa and the Middle East, and outbreaks were pretty infrequent. So West Nile virus, there was certainly a scare in 2020 when there was an outbreak in the north of Zimbabwe, and these outbreaks are infrequent. I'm not aware of another outbreak since 2020. But subsequent to 1996, there have been increasing reports of more severe illness and more of the sick dying. And the question is the virus becoming more virulent, or are we as a population becoming sicker? Because the more severe illness is largely documented in the US and in the developed countries, where it's being seen in older adults and people who have immune system problems. And the outbreaks are more frequent since 1996 than prior to 1996. But the question I think we have to ask, is that a sign of a more unhealthy population, or is that a sign of a more virulent virus? And it's probably a more unhealthy population. The screen, unfortunately, has cut off, but only about 5% of people, sorry, I can't get it to go back, actually present with severe illness. About 20% will present with West Nile fever, which has the characteristics that we've discussed before. And about 80% are asymptomatic and provide a reservoir of disease. So it's very rare that being infected with West Nile virus actually makes you sick. So when there is an announcement of an outbreak, there's definitely no need to panic. Most people do not get very sick. Most people just get a bit of a fever, and between 3 and 14 days, they present with fever, chills, a headache, and fatigue. And the headache and the fatigue can be severe. They can present with nausea and vomiting. They also can present with a rash, which lasts a few days. It's usually not itchy, and it's usually papular, and they're usually better within a week. And you can get a chronic fatigue type syndrome after this, but it is rare. If meningitis occurs, it looks just like other viral meningitis. There may be a bit of neck stiffness, there may be photosensitivity, and you will see white cells in the cerebrospinal fluid, which will be largely lymphocytes. So it'll be quite difficult to differentiate this from an HIV type meningoencephalitis or any other viral encephalitis. And it probably isn't particularly important to withhold treatment until you've got a diagnosis, because again, we need to be making these kind of diagnoses clinically. If your patient has encephalitis, the severity will range from mild confusion, and very, very rarely you will get coma and death, and that is usually in the elderly and in the immunocompromised. And those who have chronic medical problems are much more likely to progress to encephalitis, and that's probably because their immune systems are not functioning at full capacity. One of the other sets of symptoms that will come with people who have West Nile virus encephalitis, they can have tremor and myoclonus, which is the quick, uncontrolled muscle jerking, and they can have problems with balance and dizziness. But this is seen in all forms of encephalitis. What is interesting, and this is a question Dr. Carvalho actually raised, given that we're talking about increased incidence of polio in the region, you can have a flaccid paralysis, and that has been seen more frequently, and it may present in 15% of people who have severe illness, and it will affect relatively young people who are often healthy otherwise. Most cases of West Nile virus associated weakness that persists have weakness early in the infection. It's often only in one limb, and they usually don't have any numbness. So these are the kind of things to just be aware of when you think that a patient may have polio or you think they've got a viral meningitis. Bear in mind that make sure that you're getting a history of whether there have been mosquito bites in the last 14 days. And this is really just to raise awareness. But I don't think the management would be that different. Can we please mute? Thank you. So testing is usually obtained through the state health departments, and you would need a CSF sample, which most of us are not going to do in a primary care setting. And you will find an IgM in the CSF if you look for it. But it's a highly specialized test, and this is if you wanted a definitive diagnosis. You can get an IgM antibody in the blood, which may persist for up to a year, but it could be due to a previous infection. So if we look at illness outcomes, only if you get severe disease, which is in less than 5%, 10 to 20% will actually die. And the CDC say that it's unknown why some people do not get sick and some get extremely sick. But common sense would tell us that the better your immune system is, the less likely you are to get a hemorrhagic fever caused by West Nile virus that involves meningoencephalitis. So let's look at what happens with Ebola, Marburg, dengue, West Nile virus, all of the viruses that can cause hemorrhagic fever. First of all, they have to breach the mucosal layer. So mucosal immunity becomes very important. And particularly in the gut, the better your gut immunity is, the less likely you are to get sick. And this is quite a busy slide, but there's a few things in here that are important. And that is that your immune response is going to determine how sick you get. And that in the central part of the slide, you will see that if you get a massive immune response and you make a lot of pro-inflammatory mediators, also known as a cytokine storm, you are going to activate your coagulation cascade, which means you're going to drop your platelets and your D-dimer is going to go up and you may bleed, and the endothelium may result in clotting because viral hemorrhagic fever is basically the same as DIC or disseminated intravascular coagulation. And early treatment may avoid this completely. The systemic dissemination, these things, the viral hemorrhagic fevers go to the brain, the adrenal gland, the liver, the spleen, and obviously testing will pick that up, particularly in liver functions. But one of the important things to do is to remember in some of these cases where you might not have access to lumbar puncture, that if you check, you're looking for low platelets and you're looking for a raised D-dimer. And the D-dimer goes up about 3 days before the platelets drop and bleeding occurs. What we also know is that you start to get vascular permeability and vascular leakage, and then you drop your blood pressure and get multi-organ failure in those who are susceptible, who will progress to severe disease. Now, if we look at Ebola as an example, the outbreaks are rare. They are usually easily contained by standard measures. Supportive care usually works. And so even if there is West Nile virus around, minimal people could get sick, and it should be relatively easily managed. Again, these are Dr. Carvello's slides. The mucosal barrier has to be breached. You will get systemic spread. Immune system dysregulation will allow the virus to replicate. And then when you get to the circulatory system, you will end up with a coagulopathy, damage to the endothelium. And that is when you get the clinical picture of viral hemorrhagic fever. I'm going to skip that slide. So a lot of people ask, in viral hemorrhagic fever, including Ebola, Marburg, West Nile fever, how does the virus kill the host? And the answer is the virus doesn't kill the host. The virus enters, it replicates, it assembles, it's released. And as a result of that, our own immune systems, if they are dysfunctional, will result in excessive inflammation, and that leads to hemagglutination, which leads to thrombosis. And once thrombosis occurs, we get consumption of clotting factors and hemorrhage. So Dr. Carvello's interest, because in Zimbabwe, we used his work to show that ivermectin was able to prevent progression, or in fact, getting the disease at all. He published a paper in 2020 where he demonstrated that if you gave ivermectin to people exposed to another RNA virus, then 58% of people in PPE got sick and no one in the ivermectin group got sick. So his interest in ivermectin came from the treatment of dengue. And that's a very important thing for us to understand if we ever face a viral hemorrhagic fever, because we now know what works as a broad spectrum antiviral against mRNA viruses that cause cytokine storms, that cause thrombosis, and then may cause hemorrhage. So again, getting back to the cytokine storm, it is not the virus that causes hemorrhagic fever and shock and immune failure and renal failure and bleeding. What is actually happening is the cytokine storm is precipitating thrombosis. During thrombosis, clotting factors are consumed. The D-dimer goes up 3 days before the platelets drop and bleeding occurs. And it's fairly well documented that if you detect this before bleeding occurs, the treatment, which may sound counterintuitive, is to anticoagulate the patient before this happens. So it's exactly the same mechanism as what we've been dealing with for the last few years. But in COVID, the clotting is so severe that the clotting will kill you before you bleed. In hemorrhagic fever, the virus is actually less virulent. And so it causes progressive clotting until the patient actually hemorrhages. So if we're going to look at how to stop any viral hemorrhagic fever, if you're in Argentina and you've got a lot of dengue, they have a lot of dengue in Asia as well. If we're here with West Nile virus, if you're in Uganda and you've got an Ebola outbreak, what can you do? Well, the first thing you need to do is stop the virus entering, stop the virus replicating, stop the virus assembling, and stop the virus from being released. If you do that at an early stage, and you can do that in contacts of people who've had Ebola and Marburg, if you treat the contacts and boost their immune system and give a broad spectrum antiviral, you would technically stop a cytokine storm, and you would therefore stop the thrombosis, and you would therefore prevent the hemorrhage. So to get into that kind of mindset, we need to understand that to stop the bleeding, you must stop the clotting. To stop the clotting, you must stop the cytokine storm. And to stop the cytokine storm, you need to stop the virus. Now, I'm not going to get into vector control. Dr. Newton Haemorrhagic covered vector control very well with malaria. So, stop the virus from getting in you at all, you need to stop the mosquito. So I think that we need to be aware that the reason that we need to use insect repellents and mosquito nets and all the things that are done to stop malaria, these measures will also stop all mosquito-borne illnesses. And in our area, the most likely thing that's going to be mosquito-borne is going to be West Nile virus. So stop the mosquitoes. And then if you don't stop the mosquitoes and you are bitten and you get sick, you need to primarily stop the virus in the early stages. So let's start looking at the treatment. As is true for most viruses, there's no specific treatment. There is one exception, and I'll get into that in a minute. But there are many things that have been tried. Interferon gamma was tried with HIV. It was tried with COVID. It had limited effect because it is an immune booster. You can use West Nile virus specific immune globulin, but it's very, very expensive to produce. And you can actually these days, and they're doing it in the USA at the moment, make antisense RNA. But again, these are very expensive processes that are generally not available to our community. So Dr. Martin Wucher, who will also be speaking at Victoria Falls, speaks about thinking outside the box in Africa. So one of his examples is that if an aeroplane were to crash in the sea and there were only 50 certified life rafts and there were 90 survivors, would you grab on to anything else that was floating, even if it didn't follow international guidelines? And the answer is clearly you would. You would grab onto something that somebody threw you from a rescue vessel, like a pumped up car tire, or like a 5-liter empty container with a lid on it. You would do whatever was required to survive. And the good thing about being African trained doctors with ASAP, African Solutions for African Problems, if we understand the basis of the disease and we understand the progression from viral replication to cytokines to thrombosis to bleeding, there's lots and lots of points at which we can intervene in a sensible way. So if a patient presents to us in the stage where they have fever and a mild illness, would we not treat them with a broad spectrum antiviral? And as we've discussed with multiple other intracellular pathogens, first of all, you need to be using antiviral treatments, and those antiviral treatments need to generally be combination therapy. We need to be using anti-inflammatory agents, which include steroids, and we need to be using antithrombotic agents about 3 days before the bleeding occurs. By the time the patient is already bleeding, you are probably in quite a lot of trouble. And what they're using a lot of, interestingly, in Argentina, South America, and in Asia, is something called pawpaw leaf extract. And that is currently being researched because it brings the platelet count up. But the message that people need to realize in viral hemorrhagic fever is the reason you are bleeding is the same reason as a DIC. You are bleeding because you've consumed your clotting factors. So if we go through all the different kinds of virus, the really highly virulent ones that we really need to know about are Ebola and Marburg. They are highly virulent. The others, I think we are pretty much isolated to, other than yellow fever, They exist much more prevalently in Asia and in South America, so we probably don't need to be as vigilant about them. But the important things to notice is that the incubation period is up to 21 days. And if a patient has been sick, they've usually been sick for quite a long period of time before they present with bleeding. So you don't want to be waiting until you've got someone with meningitis, encephalitis, and bleeding, because you've then got a situation that's quite difficult to treat. So the real message is that if you've got a patient presenting with fever and basically, if you've got a patient who's presenting with fever, it's a good idea to do a D-dimer as part of your workup, because you will pick up a patient who is clotting. The general principles for supportive care are obviously that you really want to minimize the transmission of infection if you are treating one of these patients. So in a patient who has got hemorrhagic fever, you want to absolutely minimize your contact with their body secretions. When they talk about supportive treatment, a lot of doctors will go, oh, well, it's palliative care. That's not the case at all. You need to keep the patient alive while you institute antiviral, anti-inflammatory, which would include steroids, and if necessary, if the D-dimer is very raised, you might be wanting to give anticoagulant therapy. And it's essential, absolutely essential, as it has been in the last 4 years, make sure that you give attention to the fluid and electrolyte balance. You may need therapy for shock and you may need therapy for blood loss, but the objective is to keep the patient alive while their immune system takes care of the problem. It's exactly the same care as conventional care provided to patients with other causes of multi-organ failure. And if the patient has respiratory distress, you would be giving oxygen. If they're in renal failure, you might dialyze them. If they have seizures, you would give them anticonvulsants. And as it says, you might need to ventilate, dialyze, and give neurological intensive care. To date, if we look at the studies, the therapeutic use of heparin or corticosteroids has not been proven effective once the patient is in the hemorrhagic stage. So it's a case of early recognition and not letting the patient get to the stage of ICU. We certainly learned that over the last 4 years. Once you have a suspicion of a clinical diagnosis in COVID, you want to be treating them in the viral replication phase, not in the multi-organ failure phase. So the treatment we want to discuss tonight is ribavirin, which is given intravenously as a loading dose and then 6 hourly, and it can be given prophylactically as well. And for those of us familiar with HIV care, we know that antivirals come in different categories. So you can have an integrase inhibitor and you can have a nucleoside agent that interferes with the synthesis of viral mRNA. This is just like HIV treatment with nucleoside inhibitors. So ribavirin is metabolized into a nucleoside analog that blocks viral RNA synthesis. It's also used in hepatitis C, and it is licensed for use in viral hemorrhagic fever. And for those of you that like your biochemistry, it basically acts by mimicking guanosine, which is one of the 4 bases involved in RNA replication. Going back to analogies with COVID, we know that in the early stages, stage 1 will be while the virus is replicating, and you will have a patient who may present with fever fatigue, myalgia, diarrhea, nausea, and vomiting. If you were in the middle of an Ebola outbreak in Uganda, this patient in its context would be quite likely to have Ebola. If we're in Zimbabwe, probably in your differential diagnosis of a patient who presents with these symptoms, you might want to put West Nile virus. When the patient progresses into stage 2, which is at 7 days, which the 7 to 8 day rule was very consistent, particularly in the beta stage of COVID, the patient, if their immune system is not coping, or if the immune system is dysregulated, particularly if they're diabetic, if they've got metabolic syndrome, and if they've got comorbidities, the patient may progress into all the things that we saw in 2020 and 2021, which include acute respiratory distress, and they include this DIC type picture with a high D dimer and low platelets. But unlike COVID, the hemorrhagic manifestations are much more likely to occur in stage 2, which we would have seen at the time compared to COVID. It would be in the hypoxic stage of the illness. And stage 3, the patient goes into multi-system failure, and you really don't want to get to stage 3. We've been focusing on early treatment and combination therapy. So I'm going to skip that slide. Let's look at the immune response. What did we learn from the leprosy lectures? We learned that a poor T cell response results in much worse infection. We know that from HIV, we know it from leprosy. So neutralizing antibodies are part of what will protect you. But if you're going to have fatal disease, it's most likely to be a CD4, CD8 problem. And you are much more likely to have fatal disease in any viral illness if you have low CD4 and low CD8 cells, and any reduction in your natural killer cells. So anything that boosts a T cell response will definitely help. And anything where there is low T cells, which would include HIV, is more likely to cause severe disease. So getting back into immunology, I'm not going to go into the slide in too much detail because it's late and Dr. Corvella still is not on the call. But we do know that our adaptive immune response is really what protects us. And our T cell response, particularly a Th1 response, and using interferon will activate T cells and will cause immune activation. So finishing up with going back to basics, if you don't have ribavirin and you are in a situation where you are faced with any mRNA or any RNA virus, and RNA viruses include all the respiratory viruses and all the viral hemorrhagic fevers, and it includes HIV as well. What do we know about RNA viruses? This is an Ebola virus. We know that the virus has to attach to the cell. What coats glycoproteins that cause binding? We know that ivermectin and argentin both block attachment of the virus. The virus is then taken up into an endosome, and the lysosomal response acidifies the endosome, and the destruction of the virus allows RNA to escape into the cytoplasm. What happens if you can block it from getting out of the endosome? What drugs block the endosome? Hydroxychloroquine and chloroquine both stop release from the endosome, and interestingly, so does azithromycin. So azithromycin has an antiviral effect as well as an antibiotic effect. Then what is going to stop viral transcription and replication? We know that zinc and all of its ionophores, which include hydroxychloroquine, chloroquine, doxycycline, ivermectin, quercetin, and artemisia, we know that zinc ionophores stop viral replication. And then the other thing the virus has to do is it has to produce its proteins in order to be able to assemble. So we know that if we stop the virus from translating, so it's a bit like a car assembly plant. You can't put the car together if all the pieces of the car don't get made. And doxycycline doesn't really care whether you're a virus or a malaria parasite or you're a bacteria. It will stop RNA translating into proteins because it binds to the subunit of the ribosome. And so when you start combining these medications, you can shut off intracellular replication of most RNA viruses, including the viral hemorrhagic fevers. So I look forward to meeting Dr. Carvello in Victoria Falls in July, and he will be able to discuss the management of mosquito-borne infections, including hemorrhagic fever and malaria. And he, unfortunately, he still hasn't come onto the call, but I've actually got his ticket in my hand, so he should be landing into Victoria Falls to answer our questions because he's very experienced in the use of ivermectin. So with that, I hope I've finished by 7:15. Yes, I have. And I'd like to open the floor to any questions. Has anybody on the group had any experience with West Nile virus? Because we've certainly had reports that it is present in Zimbabwe. Nope. Okay, if there are no questions, I'm going to take advantage of what has been an extremely interesting day in Harare with all of our traffic closures. And I know our staff are going to struggle to get home this evening with some of our arterial roads closed. So thank you, Dr. Van Rooyen. I'm not sure if you want to make any comments with your genetic knowledge of how these viruses operate. So, Sibusiso, is ivermectin effective against CCR5 and CXC4 glycoprotein receptors? I actually do not know the answer to that specifically. What I can tell you is that the effect of ivermectin in spike protein conditions is that it electrostatically binds to glycoproteins. So glycoproteins carry, in general, a positive charge, and anything that is negatively charged or carries excessive electrons will tend to coat them. And using computer simulation modeling studies, you can predict what is most likely to bind to a specific glycoprotein. So the three molecules that were predicted to bind to the spike protein most effectively were ivermectin, azithromycin, and heparin, interestingly, because heparin does not just exert its action with an anticoagulant effect, it also exerts its action by binding to glycoproteins, and glycoproteins are the receptors by which viruses enter the cell. So I'm not sure, but I can certainly ask that question of Dr. Carvello. He's the expert in hemorrhagic fever. How effective is the West Nile virus vaccine is another question. As far as I know, it's less than 70% effective. I think if there's one thing that the planet has learned, to quote Dr. Peter McCullough, is that you can't vaccinate your way out of an active epidemic situation. So once you are in an epidemic, and these things tend to come in outbreaks, you can't vaccinate your way out of a yellow fever epidemic, as an example. So when you make a decision, particularly an economic decision, to vaccinate everybody in a country, you need to look at what the cost of that vaccine is, and you need to see how many people are dying from the condition. So is it worthwhile, for example, in Zimbabwe, to vaccinate against dengue fever? Well, clearly it's not, because we barely ever see it. So it would not be a cost-effective decision, because dengue doesn't kill anyone. However, if we are going to look at conditions where there's a very high mortality rate, malaria is an example, then if we know that there's a vulnerable population living in an area where malaria is very severe, you can make a case for spending the money on preventing 70% of the population from getting severe disease. So I think I wouldn't recommend, in the Zimbabwean context, to recommend the West Nile vaccine. We have much bigger priorities. The biggest cause of death in our country is TB. We should be actively spending money on detecting and treating cases of TB rather than worrying about hemorrhagic fever. So I wouldn't support vaccinating the whole population or even subsets of the population against something that is very unlikely to kill people. You would be a lot better off, as we've discussed before, with the CD Zinc campaign. If you can boost the immunity, particularly of the vulnerable, by giving high-dose vitamin D, and when I say high-dose vitamin D, we would be talking about 50,000 units twice a week in Zimbabwe, because that's what's available. Giving people vitamin C, which is very cost effective. You can give 500 milligrams every 2 to 4 hours, and that will get someone's immunity up very, very well. Professor Ian Brighthope in Melbourne feels that intravenous vitamin C would be predicted to stop all hemorrhagic fever. And as we know, scurvy is a disease that results in hemorrhage. And one of the important things in someone with hemorrhagic fever is to ensure that their vitamin C levels are high, or they're at least getting vitamin C while they're in hospital. And then zinc is obviously very important for its antiviral effect. So if you were going to look at something cost effective, would you give a vaccine, or would you rather boost the person's innate immune system and their natural immunity? And I know in Zimbabwe we fortify food with vitamin D. I'm sure that may be part of why our numbers, our mortality was much better than everybody else's. We get a lot of vitamin C in Zimbabwe because everywhere you go, there are tomatoes on the side of the road. And I think the percentage of the population that survive on tomatoes as part of their diet is very high. And we have very, very affordable zinc supplementation, which the public health discussion with people, anybody who gets diarrhea in this country will usually go to a pharmacist, and the pharmacist will almost always give them zinc sulfate. So I think immune boosting would be far better than spending the money on vaccination, and educating on immune boosting would probably not only prevent West Nile virus, but the value added part is that it would protect people against all viral disease. In the same way, if you wanted to stop West Nile virus, you would stop the mosquitoes. And the sidekick from that is you would reduce malaria. So I think we need to become less focused on one of the biggest money makers in the pharmaceutical industry, which is vaccination, and start focusing on other ways of either treating a disease early or of boosting our natural immunity. And the last way is stop destroying our natural immunity with poor diet and toxins. So the prophylactic dose and frequency of ivermectin against West Nile virus, it hasn't been tested is the answer. We do know the numbers for dengue. So 12 milligrams once a week used in Argentina prevents dengue. The other very interesting thing is that if you treat mammals, not only humans, it includes anything that a mosquito bites. If a mosquito bites somebody who has ivermectin in their bloodstream, the life of the mosquito is reduced from 8 days to 4, and the females are unable to reproduce. So ivermectin is also involved in vector control, and for dengue, they use 12 milligrams once a week, which is what they were using when they found accidentally that people using ivermectin to prevent dengue were also not getting COVID. That discovery came, and that's what I wanted Hector to present on, and he will present on it in Victoria Falls. The discovery of ivermectin in COVID in Argentina was discovered because they were using the ivermectin to prevent dengue, and people who were taking it were not getting COVID. No, I'm just checking that I haven't missed anyone in the chat. I think those are the major questions covered. Great. So I think the message that I really wanted to get across tonight, because there's been a lot of media coverage talking about pandemic X and what are we going to do if we get Marburg, and what are we going to do if there's an outbreak of Ebola, and what are we going to do if there's avian flu, swine flu, bird flu. You sort of will run out of animals at some point. The answer is we are going to use a broad spectrum antiviral treatment in Africa, because we know how to treat RNA viruses in Africa. We've been doing it for a long time, particularly interestingly in the veterinary industry. And we know that zinc and its ionophores will combat all RNA viruses. It's not a cure, it's part of a combined therapeutic approach. And we know that the ionophores of zinc will stop mRNA replication. We know that azithromycin and doxycycline not only prevent bacterial superinfection and treat bacteria, they are also antivirals in their own right. And we also know, which is an aside, that the combination of doxycycline and azithromycin will kill mycoplasma, which is often undetected. There is a very long joke that can be told that would be a good way to end what has been quite an interesting day in Harare. And that is that if you're in the bush and there's a predator behind a bush and it's rustling, and you have multiple medical specialities there, the neurologist will want to do a scan to see what it is. And the pathologist will want to get some blood out of it and deduce what it is using ELISA techniques and maybe even PCR. The microbiologist definitely is going to want to do a PCR, and the cardiologist wants to do an ECG and maybe an echo, because you need to know what it is. And in walks the critical care or the primary care physician, and they take out a shotgun and they blow whatever's behind the bush to kingdom come. And all the other specialists say, but what was it? And the primary care doctor says, I don't know and I don't care, it's dead. And while that may not be an academically and politically correct approach, I think it is an approach that most African doctors use in the interests of time. Because if you've got 20 to 30 people to see, you don't have all the fancy laboratory and imaging equipment. You've sometimes got to do the best that you can with whatever you've got in a logical combination if you understand how to inhibit viral replication and how to boost the immune system. So, Dr. Shane Gerber, well, I certainly don't trust anything to do with the name you've put there, but azithromycin in its generic form has a very definite mode of action, which is, and that's why it combines so well with hydroxychloroquine, it prevents escape from the endosome. So effectively, an organism that infects you, whether it's a mycoplasma or whether it is a virus, it's not going to be able to get out of the endosome if there is azithromycin, particularly in combination with hydroxychloroquine. So the fact that a drug company that has committed fraud on several occasions and has a budget to get out of trouble is making it doesn't mean we have to tar azithromycin with the brush that the drug company that is branding it is tarred with. So I'm a bit of a protector of azithromycin because I find it an amazing medication. And the good thing is in Zimbabwe, we can't afford the branded drugs. So we generally go for the generics anyway. It's an excellent molecule. I agree wholeheartedly, particularly when combined with doxycycline and zinc. Right, with that, we've got 2 minutes to go. Anybody else want to make comments about anything else that won't get us shut down and taken down off YouTube? No. Well, with that, I'm going to end the call. Pride, can you stop the recording?